Thanks so much, Eric and Gareth, and welcome everybody. It's really an honor and a privilege to be here amongst friends from Southern California, and also to be introduced by Eric and Gareth. When I did my fellowship, Eric and I were co-fellows, and Gareth was our senior junior attending who gave us a hard time. So if anybody wants to hear some good stories from fellowship, we can talk about them during the break. My charge over the next 20 minutes or so is to talk about the best of DDW with respect to inflammatory bowel disease abstracts that I've divided up with Niru Banthala, and she'll be talking after me, and we've tried to separate them by themes. But there was a lot to choose from. There were hundreds and hundreds of abstracts, so we really had a difficult time selecting what are the top ones that we're going to be talking about. And I'll give you my take on some of what I thought were the highlights from DDW in the IBD space. We'll be touching on updates in ulcerative colitis treatment, updates in Crohn's disease treatment, comparative effectiveness studies, which finally are hitting our field, disease monitoring, and we'll end up with optimization of surgical outcomes, which I believe is an area that's somewhat been neglected over the past number of decades with all the focus that we've had on drugs. The first update I'd like to touch on is the AGA Living Guidelines, Pharmacologic Management of Moderate to Severe Ulcerative Colitis, and this was presented by Sid Singh from UC San Diego, who's been a frequent visitor to this conference. And what was different about this update that I thought was very important and new to our field is the way that they presented an update for a guideline. And guidelines historically in the IBD space have not been very specific about positioning of therapies. We haven't really had the option of multiple therapies previously. For a long time, we only had one or two or three biologics. Now we have changed even the term biologics to advanced therapies because it includes small molecules, and we have many options now for advanced therapies. So what this guideline attempts to do is to actually give us suggestions for positioning based on evidence. And they framed this guideline in terms of asking three questions. First question, in adult outpatients with moderate to severe ulcerative colitis, what is the efficacy of an advanced therapy for induction and maintenance of remission? So one overarching question, and they divided the answer into high certainty of evidence, moderate certainty of evidence, and low certainty of evidence. And what you can see here is upadacitinib was high, moderate was infliximab, golimumab, vedolizumab, ozanimod, etrasimod, ustekinumab, and tofacitinib, and then low would be adalimumab and mirikizumab. Now, they didn't go into the evidence, and they stated that all of the evidence provided was based on indirect meta-analyses, network meta-analyses, which forms indirect connections between different trials, because we don't have a lot of comparative head-to-head studies in inflammatory bowel disease, let alone ulcerative colitis. We actually only have one published study of vedolizumab versus adalimumab. And so this is what was presented. Question number two was, what about patients who are naive to advanced therapies? And then the third question is patients who are exposed to prior advanced therapies. For patients who are naive to advanced therapies, meaning like what should first-line biologic be or first-line advanced therapy? Highest efficacy would be infliximab, vedolizumab, ozanimod, etrasimod. And interestingly, they put upadacitinib, which, by the way, according to FDA labeling, should not be used first-line, right? Because it's got a warning that anti-TNF should be used before prescribing a JAK inhibitor. Intermediate efficacy, golimumab, ustekinumab, mirikizumab, and tofacitinib. Same warning with tofacitinib and upadacitinib. And then lower efficacy with adalimumab. And then finally, the third question was for patients who've been previously exposed to advanced therapies, meaning what should we use second line or third line or fourth line? And here we have, again, the higher efficacy being upadacitinib, which, by the way, is the only drug that made it in the highest category for all three questions. Tofacitinib and ustekinumab as well for higher efficacy among TNF or advanced therapy experienced patients. Intermediate efficacy with mirikizumab and lower efficacy with adalimumab, vedolizumab, ozanimod, and etrasimod. The reason that I'm sharing this with you is that there's a lot of names up here of drugs, and without going into the details, I think this is an important document really for two reasons. Number one is that we're given now a guideline that has positioning of drugs as part of that guideline. And number two is they're calling this a living guideline, which means that they've committed, the AGA Guidelines Committee has committed to making this a living document. It's not going to be published and updated again in 5 years. They say they're going to go back and update this every 6 months or when new evidence comes out that will allow them to determine comparative efficacy across drugs, because they realize that by putting in positioning, they're really going out on a limb and saying this drug looks like it might be better positioned than this drug. And so they're putting a caveat in there that any time new evidence is going to come out, they're going to update these guidelines. And of course, we anticipate that there will be a public comment period as well before these are actually published. They also give some important caveats for implementing these guidelines. Number one is that individual patient factors, of course, need to be considered: comorbidities, frailty, pregnancy. Neeru is going to talk more about pregnancy. And patient preferences, like the route of administration. We now have the opportunity to give IV, subcutaneous, or oral advanced therapies. Of course, we need to consider all of them. Safety needs to be considered, and we do see that on a safety standpoint, both in terms of warnings and in terms of what's been seen in clinical trials, the anti-interleukin therapies, anti-IL-12, 23, anti-23, selective inhibitors, and vedolizumab seem to have fewer infections. There's limited data on JAK inhibitors and S1P receptor modulators in pregnant women. Biosimilars, important topic, right? We all deal with biosimilars in clinical practice. Biosimilars should be considered equivalent to the parent drug, and this is based on the totality of evidence. We've also seen in the past year the introduction of subcutaneous formulations of infliximab and vedolizumab as having comparable efficacy to IV maintenance doses, and so those are now available. And then, of course, we also see in clinical trials that for some patients, extended induction or dose escalation is warranted. So let's change gears now and talk about some of our more advanced therapies. A lot of attention at DDW on IL-23 receptor antagonists as sort of the next generation of the IL-12/23. And just to remind you, ustekinumab targets both IL-12 and IL-23 receptors based on inhibition of P40, whereas IL-23 inhibitors target only the P19 subunit of the IL-23 receptor, and that includes risankizumab, which is approved now for Crohn's disease, guselkumab, which is not approved for Crohn's or UC, but probably will be, and mirikizumab, which is approved for ulcerative colitis. And so we saw data presented for guselkumab, again, not yet approved, but very exciting data for ulcerative colitis. And what you can see here all the way on the left is guselkumab for ulcerative colitis showing a delta of about 30, almost 30% between treated patients and placebo for the primary endpoint of clinical remission. And you can see across the board for all of the outcomes that were assessed, very significant deltas between placebo-treated patients and guselkumab-treated patients. And this is for 2 doses, 100 milligrams every 8 weeks and 200 milligrams every 4 weeks for maintenance therapy out to week 44. So we anticipate seeing more of this drug in the future. Stay tuned. This drug also was assessed with respect to active Crohn's disease, and what you can see here all the way on the left side of the screen for a co-primary endpoint of clinical response at week 12 plus clinical remission at week 48 when patients were treated straight through, as well as on the right side of the screen with endoscopic response and clinical response, that there were very significant deltas, over 30% between placebo-treated patients and guselkumab-treated patients in Crohn's disease. So these are very, very significant deltas, some of the biggest that we've seen ever in this field. And so this drug, again, stay tuned for what we see and what we learn. But what I've shown you is drug versus placebo. We don't have a lot of comparative effectiveness studies in inflammatory bowel disease. So it was exciting to see data presented on a comparative effectiveness study, risankizumab versus ustekinumab. We are all familiar with ustekinumab. It's been out for many years now, but risankizumab is now sort of the next generation, not just blocking IL-12 and 23, but selective IL-23 inhibition, so staying within this space. These data were actually presented earlier, and there was an update that was presented at DDW. So just to remind you all, this sequence study was a comparative effectiveness study of risankizumab compared to ustekinumab. Importantly, this was an open label study, which I believe was a significant factor in understanding this data. It's not a randomized blinded control trial, it's an open label trial, and also recognizing that these are patients that were all treated previously with a biologic. So these are they had failed at least one biologic drug. These were not naive patients. And what you can see here was that for every endpoint evaluated, the outcome was more favorable with risankizumab compared to ustekinumab. And this went through early phases from week 8 to week 24 through week 48 with respect to clinical response, clinical remission, and even endoscopic remission and mucosal healing with a SCSCD score, simple endoscopic score of 0, which is an incredibly difficult endpoint to reach. With a delta here, you can see on the right side of the screen of week 48 of 18% between risankizumab and ustekinumab. A SCSCD score of 0 means not even one single aphthous ulcer in the ileum or in the colon. So that's a very difficult endpoint to reach. And we're seeing here very significant differences between two drugs, not just drug versus placebo. And what was shown at DDW, the update here, was that not only are the clinical parameters better with risankizumab than ustekinumab, but also the biomarker reduction was more significant, with a more significant drop in CRP and a more significant drop in fecal calprotectin, with an average of about 500 micrograms per liter in the ustekinumab arm compared to 1,500 in the risankizumab arm for calprotectin. So you can see here again that across the board, clinical parameters, endoscopic parameters, biologic parameters, all better with risankizumab. Again, with the caveats that this trial was open label and also that this trial was with patients that were already experienced with a biologic drug. I think that what we're going to end up seeing is that ustekinumab is going to become sort of a comparator drug for other IL-23s. And the big question is, are all IL-23s created equal? And this is not yet a question that we know the answer to, but I think we're starting to see that there will be ways that we can evaluate these drugs independently or with indirect comparisons, like we have seen with placebo-controlled trials. Moving on, I think another important trial to talk about from DDW is the Darvadster study. This was the stem cell study for perianal Crohn's disease. And there was a lot of interest in this because this is already approved in Europe and Japan. It's already being used. And a lot of patients suffering from perianal Crohn's disease, as we all know, this is very difficult to treat with very significant morbidity. Up to 30% of patients with Crohn's will have perianal manifestations with a complex perianal fistula. This is an expanded adult allogeneic adipose-derived mesenchymal stem cell that is injected by the colorectal surgeon into the fistula tract with the idea that these stem cells will allow for fistula closure and healing. And as I mentioned, it's already approved in Europe and Japan based on a study showing 50% healing in treated patients compared to 34% placebo-controlled patients. And just remember that number, 50%, that was the number that this now second study in the US was powered to achieve. And what did it show? Disappointingly, there were no significant differences. Both of them were approaching 50%, both the placebo arm and the treated arm at week 24, which was the primary outcome, and looking also at week 52 and the combined outcome of clinical remission at week 24 and week 52. Clinical remission, by the way, defined by complete fistula closure and no evidence of any abscess on MRI. No difference between the two arms. So looking also at different ways of assessing, slicing and dicing the data in different ways. What drugs were the patients on? Maybe those that were on biologics or those that were immunomodulators might have done differently. And we can see really there was no significant difference between the two arms for any of the analyses that were done. So the conclusion of this study was really that this was a negative study, that treatment of complex Crohn's perianal fistulas with this stem cell product showed no significant or meaningful differences compared with placebo, and this was probably due to an unexpectedly high response rate in the placebo arm. If you look back at the placebo, what did they do in the placebo patients? Just like in the treated patients, there was a curettage of the fistula tract by the surgeon very meticulously, and perhaps it's that curettage of the fistula that was done so meticulously in the placebo-treated patients that may have allowed for that significant fistula closure rates that were seen in this study. So disappointing in the sense that this is not probably going to be moving forward in the United States on the basis of this trial, although we'll see what the company decides to do. But on the other hand, perhaps we've learned how a surgical technique for addressing fistulas needs to include that very meticulous curettage of a fistula tract. Moving on, another area that I thought was very interesting and important in IBD that was discussed at DDW was intestinal ultrasound. And this was a study, not the greatest sort of methodological study for ultrasound, but I think drives home a very important point. Point of care intestinal ultrasound is the ability to do ultrasound in the clinic with the patient right there coming for their visit by the gastroenterologist to determine disease activity. And it has been shown to be very highly associated with what one might see on colonoscopy and certainly with inflammatory biomarkers that can be determined right then and there at the point of care. It can be performed during a clinic visit and is sensitive to changes in the bowel wall thickness as well as flow of blood flow in an area of inflammation as soon as a day or a couple of days after starting therapy. So this is highly, highly sensitive to determining changes in inflammation that can be visualized again at the point of care. So the aim of this study was to look at patients that were basically had decisions made using ultrasound versus patients that had decisions made using conventional care, how we might otherwise assess inflammation. Well, let's schedule you for a colonoscopy. Let's get a fecal calprotectin. Let's schedule you for an MR enterography. Well, that's going to take a few weeks, and then we got to get authorization. But with ultrasound, you can do it at point of care. So what the study was saying, well, what were the outcomes of the patients that were managed with the ultrasound strategy compared to patients that were managed conventionally? Their primary endpoint was time to treatment change from the time that they saw the patient until the time a medical decision was made. And then a secondary outcome was time to clinical remission from making that change. And what you can see here is that the average time to making a treatment change in the ultrasound group was 2 days, compared to 25 days for the patients receiving conventional management, right? Because then with conventional management, you got to wait for the scope, you got to wait for the calprotectin results, you got to wait for the other things, as opposed to ultrasound, which can see them all right away. And the average time to clinical remission, similarly, no surprise, was much shorter in the patients that were managed using an ultrasound-based strategy. So I think that from my standpoint, this is an important study to highlight because I do believe that this is paradigm shifting in our field in inflammatory bowel disease. The bottleneck, I believe, with ultrasound is the training. It's actually very complex and difficult to get people trained. And there's a major backlog globally for getting people trained to use ultrasound at the point of care. But I believe 5 to 10 years from now, as more and more people are going to get the training for ultrasound, availability of ultrasound, this is going to allow us to be able to manage patients much more effectively and efficiently and in a timely manner compared to the way we do things today. And finally, I want to highlight a study that we presented from Cedars-Sinai looking at multimodal prehabilitation associated with surgical outcomes in inflammatory bowel disease. And this was spurred really by a surgical article that compared running a marathon to having major abdominal surgery, published many years ago, with the idea that the physiological stress of surgery is similar to what one's body might go through for running a marathon. And you would never run a marathon unprepared, nutritionally, physically, mentally. And so why are we sending patients to surgery without appropriate preparation? And perhaps we can find that there's benefit. And so the concept of prehabilitation is building patients up before surgery and allowing them therefore to recover faster after surgery, even more so than our current ERAS protocols, ERAS being the Enhanced Recovery After Surgery protocols. So we looked at the Comprehensive Complication Index, which is a single score that summarizes all of the complications that might happen to a patient after surgery as a primary outcome for determining patients who went through a prehab program that includes seeing a dietitian, a physical therapist, a nurse practitioner, and a social worker to assess their nutritional status, recommend immunonutrition shakes, carbohydrate loading shakes, exercises, particularly around the abdominal wall and pelvic areas, and assessment of anxiety and depression and coping skills around surgery, and providing the patients the resources that they need to get through that. So we have a 10-week program beginning 4 weeks prior to surgery. And what we found was we had 29 patients going through the prehab program, 48 patients who did not. Overall, they were fairly similar demographically, although we did have an imbalance in the types of surgeries that were performed, with more colectomies in the standard of care arm, more ileocecal resections in the prehab arm. And what we found was that there was a significant reduction in the Comprehensive Complication Index, meaning fewer surgical complications in the patients that went through prehab, as can be seen here. Not only that, but we had lower opioid consumption in the post-operative period. And very importantly, we found that the likelihood of having a repeat operation within 30 days, a reoperation, was lower by half in the patients that went through prehab compared to the patients that did not. 12% in the patients that did not, and 6% in the patients that did go through prehab. So our conclusion was that multimodal prehabilitation before IBD surgery may be associated with improved surgical outcomes, including complications, opioid use, and need for reoperation, and larger prospective controlled trials may be warranted. So that's the summary. We talked about an updated ulcerative colitis guidelines, novel being that this is now a living document that will be updated every 6 months with positioning that will help us guide us how we treat patients in the clinic. Highly effective ulcerative colitis therapy is coming soon. We already have some fantastic drugs, and we'll see more in the IL-23 space with more data to guide us on comparative effectiveness between studies. Stem cells are unlikely to be seen anytime soon in the clinic for perianal disease, at least in the United States. If you want to use it, you might send your patients to Europe or Japan. Ultrasound for IBD management is probably going to be a new paradigm of care globally over the next 10 years, and prehabilitation improves surgical outcomes in IBD, and more studies should be coming forth soon. Thank you very much.